I would like to thank you, Dr. Sabri and Boston in Egypt for supporting the VT camp in the last weekend. It was a very nice meeting.
Thank you, doctor. It's one of our commitment to the field.
Yes, yes. We wish that all companies will support this education agenda for anyone who wants to do something, and which the feedback is all over the EP specialists.
Sure, inshallah. With the next, yeah, sure.
I was also lucky to be there on Friday.
I saw you. But I could not stay till the end of Friday. It was very late.
I see. It would have been nice to meet in person as well.
Yeah. We have 1 more minute to wait.
So we have 1 hour, right? 60 minutes.
Yes.
Okay. I will
By
try
the way,
to.
This is the educational. This is I invented the Egyptian diploma of EP under Ain Shams University. Actually, I'm one of the students in this diploma, although I am 64 years old, but I'm still studying. So in this diploma, it's a whole 1-year program for people who have PhD degree in cardiology, then they want to go into electrophysiology. Our education schedule is every Monday on Zoom, 2 hours. We give presentations of high-level electrophysiology, not the basic, because we are supposed to know the basic from our experience. And then we give this chance for the companies like Boston, St. Jude, Medtronic, Biotronic, Sorin, to present the latest technology they have. So I'm lucky that we start by Boston, which has the best technology. Now we can start. You can introduce yourself again, please.
Enter a microphone. Can you still? Can you hear me?
Yeah.
Yes. Yes.
Okay. Can I start?
Yes, please.
Yeah. So thank you very much for the opportunity. It's my pleasure to be with you tonight. Let me just quickly introduce myself. My name is Mihai Shubkegel, and I'm working for Boston Scientific, and my position is the CRM Training and Education Manager for Growth Emerging Markets within the company. And it's my pleasure to present some of our technologies to you tonight. So I hope you will enjoy it, and I hope I can tell you some new things that you haven't known until now. So first of all, I was asked to present to you about our heart failure diagnostic tools and monitoring tools in our devices. So the following slides will show some of these tools that you can use in your clinical practice with your patients. And just for your information, these tools are available in our latest techie device platform. And the nice thing is that these are both available in the ICD and CRT-D devices of Boston Scientific. So let's see what we offer in our devices. First of all, I will show you some details about the heart failure sensor suite. The heart failure sensor suite is a collection of different sensors, a bunch of sensors that are collecting very important data from the patient via the implanted device. And then you can read all those sensor readings through the programmer of Boston Scientific, or also our remote patient monitoring system, if it's available in the actual country, which is called Latitude. So that is our remote patient monitoring system. Let's see what our devices have inbuilt in the cans. So here you can see the contributors in the heart failure sensor suite. With blue letters, you can see the ones that are new to the Resonate platform. And with a little tick mark, you can see the ones that are unique to Boston Scientific. For example, Sleep Incline is a very nice new diagnostic tool in our Resonate platform, and it's also unique to Boston Scientific. You can read the others as well on the slide. I have to highlight that two of these sensors, such as the weight scale and the blood pressure monitor, these are obviously not inbuilt into the CAN, but these are related to our latitude system. So in this case, you have to give these devices to the patient, and of course, the patient needs to be compliant, and they can take their measurement on a daily basis. And the measurements can be read by the latitude communicator, and the communicator can transfer the data to the cloud and to the latitude system. So all other sensors are built into the devices. And why are these important? Because each of them translates into some regular clinical questions that you may raise to your patient when you see them in the outpatient clinic or when you see them for follow-up. So I'm pretty sure that you are all familiar with these and you are using these very general questions when you are investigating the heart failure condition of a patient. But we also know that the answers to these questions may be very subjective. So one patient may give a different answer than another patient would. For example, if it comes to the sleep incline sensor, physicians usually ask their patients that, how many pillows do you sleep with during the night? And you can imagine that one patient may sleep 10 very small pillows, just as an extreme example. Another patient may sleep one huge pillow. So the answer is really not objective, but with a sensor reading, it can be objectively investigated. Let's see in a little bit more details what each sensor provides to you in your clinical practice. So if you look at the activity level sensor, then you will see that how many hours the patient is spending daily with activity, with physical activity. And we know that when a heart failure patient's condition starts deteriorating or starts worsening, then the activity level may go down. You have to look for a decreasing trend in the sensor reading. And if you have, if the weight and blood pressure scale and monitor are available in your country, then you can also evaluate the data that is read by these devices from the patient. So of course, if you see an elevated weight over the time, it may tell you that there is congestion in the lungs of the patient. So it may mean some weight gain due to fluid accumulation in the lungs. And also, if you see some changes in the blood pressure, that can be very important for your clinical decisions. Then the daily heart rate gives you the information about the 24-hour average of ventricular beats, which are both paced and sensed beats. The next one is the heart rate variability. So again, we know that in a healthy patient or a healthy person, the heart rate variability is broader than in a sick patient. So if you see a reduction in the heart rate variability, that's also not a good sign. So then you can act accordingly on that. And we know that the normal range in a normal normal subject is around 127 plus minus 35 milliseconds. The next one is the AT-AF burden. You can also find it in earlier devices of Boston Scientific, and then it was called atrial burden. So it gives you information about the number of hours per day the device spent in ATR or atrial tachy response mode switch events. And here you have to look for events that are more than or burden that is higher than 0. Then the night heart rate is also very informative, and it can also be very predictive of worsening heart failure. The device will check the average heart rate from around midnight in the night And so between midnight, almost midnight, and almost 6 o'clock in the morning. So it will record the night heart rate as a trend for the actual patient. Then the next one is the percentage of the LV paced. So it will give you information of the percent of all cardiac beats that were paced in the left with the left ventricular lead. And the level of CRT therapy delivered, lower numbers could indicate loss of CRT therapy. And here you have to look for decreases. The last two are the RV rate during AT-AF. It displays the mean and maximum RV rate during an ATR mode switch event. And the last one is the V therapy, where you can find a quick summary of ventricular therapy, such as ATPs and shocks delivered by the device. So these are the different trends that are available in the heart failure sensor suite. Now look into some of them in more details. Probably the most interesting one is the sleep incline sensor. As mentioned before, this gives you an objective information how your patient is spending the night. So in what angle the patient is sleeping over the night. And we know from the MultiSense study, where Boston Scientific first investigated the sleep incline sensor, that patients who had no symptoms, they were sleeping in an average of 12 degrees from zero, from the supine position. And those patients who had orthopnea or paroxysmal nocturnal dyspnea, they had an average sleep incline of 26 degrees. So the take-home message here is that an elevated sleep incline, so an elevated angle, can predict worsening heart failure if you see an elevation over the time. For this sensor, every device needs an initial calibration. So after the implant, the device starts, or the sensor starts collecting raw data, and it takes around one week or 7 days to set up the sensor itself. 7 days because most countries, I hear some background noise.
Excuse me, I have to mute all.
Yes. Oh. Can you still hear me?
Yes, we do hear.
Yeah, thank you. So the device needs, initially after the implant, needs 7 days to calibrate itself. So you can perform this calibration, I mean the patient calibration, after 7 days or during the first follow-up, which is usually after 1 week in most of the countries when you check the wound of the patient. And you can see in the next slide that it's a very simple process. So first of all, you can see, this is a screenshot from our programmer. On the top here, you can see where you can activate the heart failure sensor suite sensors. So it will activate all the sensors that I described before. And below that, you can see the sleep incline part, which needs a calibration, as I said before. So you can see that it's switched on, and you just hit this little button, which says calibrate. And then it's really, really simple. You just have to tick which side the device is implanted on. Most of the cases, of course, it's a left-sided implant. Then you just have to teach the device what is 90 degrees or upright position, then what is 0 degrees or supine position. Both of them take just a few seconds, so it's really simple and quick. And with this, you basically teach the device how to read the different sensor readings. As you can see here, it takes maximum 10 seconds, so it's very quick. Then the device, yes, please.
Someone is talking, يا جماعة. Who is talking?
Of course, if there are any questions, I'm happy to stop at any time. So please let me know.
These are children nearby. Someone. Don't worry. We don't hear you now. Hello? Hello, Michelle. Michelle? بعد ده اوكي راح فين؟ Unmute yourself, please, Michelle. Okay. We don't hear you. Yes.
Okay.
Oh, yes, we hear you very well now. Okay.
Okay, thank you. I saw a message that everybody was muted, so maybe that's why I was talking all the time, but...
No. I just muted them when I heard the children with someone, and then I asked you to unmute yourself.
Yeah, but unfortunately, I didn't have the button anymore, so I couldn't do it. But okay, it's good that you hear me now. So the next one is the thoracic impedance sensor, which is also a very useful tool because we know that with heart failure worsening, in most of the cases, fluid is accumulating in the lungs. So it's also a very informative tool in the heart failure diagnostics. So as you can see on the left-hand side, the device will give you a nice trend over the time, where you can see changes in the thoracic impedance trend. And it correlates very well with the pulmonary capillary wedge pressure. And we know that the impedance will decrease with the thoracic congestion. So again, it's a nice tool. So let's see some examples. And these examples are taken, we jumped to the next one, which is the respiratory rate, which can also be detected by our devices, and you can also get a very nice trend over the time. So the device can measure the respiratory rate and also volume in the patients. And these are three different examples that were taken from the MultiSense data. It was our study where we investigated this sensor as well, together with the sleep incline sensor that I described before. So in the first example, in the first patient, you can see that the respiratory rate increases prior to a heart failure event because the patient cannot breathe properly. So the respiratory rate needs to increase in order to supply the patient with enough oxygen. So again, this is a very informative tool and a very informative trend that you can check in our devices. In the second example, you can see that the respiratory rate was above 20 breaths per minute, which means an elevated respiratory rate. And we know that it means 3.5 times higher risk for heart failure hospitalization within the next 1 month if you see such an elevated respiratory rate. In the third example, it was a third patient from the study. We saw that the respiratory rate, the range was higher than in a normal healthy patient. And if you see such a higher range, it can mean up to almost 5 times higher risk of heart failure hospitalization within the next month. So again, these are very, very important and very good predictors of heart failure hospitalization. And as we know from heart failure management, the most important thing is to always avoid heart failure hospitalization and decompensation, because we know that it's a deteriorating condition and it just gets worse and worse over the time. So if we can avoid heart failure hospitalization, then we can lengthen the time the patient can live a good or better quality life. Let's see another example, and I don't think we have to have the tools now, but just please make a guess for yourself. those of you who are attending the meeting, because I will explain you why I'm asking this question. So in this example, or in this quiz question, you have 3 different patients, as you can see on the slide. And in each example, you can see that the thoracic impedance trend was going down. So you have only this information. You have no other information from this patient. So my question is, what do you think? Which patient was hospitalized for heart failure decompensation?
Dr. Musa, you can answer.
تمام دكتورة ميرفت مع حضرتك.
These are 3 thoracic impedance trends of 3 different patients. Which one is going to be hospitalized, Zia Musa?
The first type A, B, and C. I can see A and C. A and C can be hospitalized, while B, I think, in thoracic impedance decreased just for a short period.
And return to the baseline. What is the correct answer, Michelle?
Yes, I will show you in a second. Patient A and C required hospitalization. That was correct. That was a good guess. Although from only one trend, we cannot tell it for sure. So why I showed you this example, it's because Boston Scientific realized that having only one sensor for heart failure diagnostics is not enough. So that's why we have the multi-sensor approach. That's why we have several sensors in our devices. And with more information, you can have a better judgment, and you can make a better decision in your patient management. And why is that important? I will show you. So in these examples, you can see the same patients. So although you gave the right answer, but in reality, from only one trend, you cannot give a precise answer, or you cannot know it for sure. Here you can see that our devices will give you different trends, different sensor readings, such as heart sound S3, heart sound S1, respiration rate and volume, and thoracic impedance. From this, you can more clearly see that patient A had changes in almost, in all the trends that are available. So you can see very clearly that this patient was really going into a decompensation. You see that multiple trends reacted. You can see in the second example with patient B that only the thoracic impedance was decreasing, so no other trends had any significant changes. And indeed, this patient was not hospitalized because it wasn't due to heart failure decompensation, but this patient only had a cold and some cough. But again, from one trend, you cannot tell it for sure. Patient C, the third patient, had changes only in 2 trends or 2 sensor readings, which were heart sound S3 and thoracic impedance. So this patient stopped their diuretics, so that's why they had heart failure decompensation. And if you look at the top of the slide, you can see the word heart logic, which is a very nice tool, again, available in our devices. And the heart logic index uses 5 different sensor readings out of those that were listed before. And as you can see on the top, there is the algorithm combines 5 different sensors, as you can see on the next slide, and it combines all the information into one single composite index. And you can set, or there's automatically set a threshold, and if this composite index crosses that threshold, the system can give an alert. And we saw it in the MultiSense study that on a mean of 34 days, the system was able to give an alert. You can imagine that you can get a notification for your patient weeks ahead of a heart failure hospitalization. So you have the chance to react on that and to change, for example, medications, or just to call the patient in to the clinic and adjust the medications or to do something before the patient would be hospitalized. I have to highlight here that for this, you need to have our remote patient monitoring system, the Latitude system, because the system makes all the calculations. The device only collects the raw data because it needs a lot of mathematics and a lot of calculations. You can imagine that. So the Latitude system is needed for this. But if you don't have this system, for example, in Egypt, you still have all the sensor readings available via the programmer. And just to highlight again, the 5 sensors that are taken into the HeartLogic composite index are the heart sounds, such as the S1, S3 heart sounds, the thoracic impedance, the respiration rate and volume, the activity of the patient, time spent active, and the night heart rate. So these are the 5 sensors that are taken into the HeartLogic index. So let's see a few slides about the user experience, what you can find or you can evaluate with our devices and our programmer. So here you can see the new heart failure management report that you can get from our Resonate platform devices. And here you can see that although the letters are very small, but the main message here is that you can see everything over the time in a very nice A4 format. And with this format and the trends being above and below each other, you can very nicely evaluate the different changes in each trend. You can see that the trends that are available on the report are the following: the thoracic impedance, the sleep incline, the night heart rate, the ventricular therapy, and also the other ones listed here in the blue box. So it's just a nice tool for your clinical practice where you can evaluate everything at the same time for your patient. Some additional features here. In the boxes at the beginning of each trend, you can find the latest sensor reading with a number. So it's again, it just makes your life easier to evaluate the changes or the readings by the sensor. What you can, or let's see where you can find everything on or all these things on the programmer. So again, this is a screenshot from our programmer. This is the main screen when you interrogate a Resonate device. And here you have the heart failure management button. So you just click on that button and you will go to the patient diagnostics part. So here you will find all the histograms, the bradycardia counters, and the heart failure management reports. So if you click on the details, you will find the different trends. So as I mentioned before, if you don't have Latitude in your country, you can still have access to these trends. So you can still evaluate them, how they change over the time. And our recommendation is to always look at the trends, not at the actual numbers, because there may be some fluctuation in the numbers day by day. But the most valuable or the most informative part is the trend, how the trend is changing over time. Yeah, so this was all about the heart failure management in our devices.
Can I have some questions, please?
Yes, please.
My question is about the sound. You mentioned the S3 and you mentioned the in 2 or 3 before this presentation.
Yeah, the S1 and S3 heart sounds.
Yeah.
Yes.
Not this slide, the one before. S1 and S3.
Yes.
Yes, here. How can the machine has a trend have it for the heart sound? How? Yeah,
it's a very good question, and thank you for asking that. So the device, the implanted device, is using its accelerometer for identifying the heart sounds. And these were investigated in the MultiSense study of Boston Scientific. And our engineers, of course, they are very, very smart. They identified very special, I don't know the engineering details, but they identified some very special frequencies that are very characteristics for both the S1 and S3 sounds. So with the algorithms, they from the frequencies that the accelerometer can detect from the patient, they can clearly identify which one is the S1 and which one is the S3 heart sounds. So from an engineering point of view, these can be distinguished by the frequency and by the pattern.
Okay, my second question, is this heart failure logic or heart logic diagnostics applicable for those who have atrial fibrillation? You said that this algorithms are applicable in ICDs and CRTDs, but if the patient has this ICD, not CRT, and is in atrial fibrillation, are these logic applicable in presence of atrial fibrillation?
Yes, so it's available in all our devices in the latest platform, so both in ICDs and CRTDs, and HeartLogic is also available, or at least the devices are capable to manage all this data and to collect all this data. Well, if the patient has atrial fibrillation, then still, these trends are collected by the device. Maybe you cannot evaluate the same way each trend if the patient didn't have atrial fibrillation, but as far as I know, it should still work. And yeah, so it can still collect all this data.
Okay. So another question, is this heart logic algorithm consume some of the battery and the longevity? Does it affect the longevity of the battery?
Yeah, it's a very good question again. As I mentioned before, the device is only collecting the raw data. And for the HeartLogic to work, we need the latitude system. And with the latitude system, the patient receives a communicator, which is plugged into the electrical source of the apartment or the flat. So all the mathematics and all the calculations are done on the server, so that doesn't consume any energy from the device. Of course, the device has to collect the data, so that always consumes some energy. But the good news is that I don't know if you are aware of that or not, but all our devices are using the EnduraLife battery technology, which is very special to Boston Scientific, and we have the highest or the longest projected longevity in the field. And the good thing is that it's not just projected longevity, but also real life longevity. So I can tell you that, for example, our latest CRT devices, which are X4 devices, meaning they can accept a quadripolar LV lead, so they are capable of multi-site pacing. So even with multi-site pacing, you can reach up to 13.3 years with a CRT device. With the Boston device, with the EnduraLife battery technology. So that's really, really high, I think. And with ICDs, of course, you can reach even higher longevity than that.
Is it available in Egypt, ya Sabri? This is for Sabri now. Is this technology available in
Unfortunately, doctor, because the latest disturbance has, due to devaluation, make a lot of obstacles with our commercial planning with Boston Scientific. This is why we are delaying it. Just once we have a stable financial situation, we're gonna recontact with Boston Scientific, trying to launch it in Egypt, inshallah.
Thank you very much. Thank you very much, Michel.
But it's important to mention. Sorry, it's important to mention that the battery technology that I just described is available also in the devices that you are using currently. So we started using this battery technology in 2008. So you can see that we already have, how many years is that? 14 years?
15 years. 15.
Yeah, or almost 15 years, yes.
For the battery technology Endura, it's available with our current portfolio available in Egypt, yes. But for further diagnostic tools, it's not available with the current version in Egypt.
Okay.
Yeah, but as you could see in the beginning, let me just go back very quickly. So some of the here you can see that some of the sensors are also available in your devices that are using now.
Yeah.
So
yes,
Respiratory is okay.
Actually, I saw it in my device, but I could not know how to get benefit out of it. A question about the blood pressure. You give the patient a cuff machine to measure his blood pressure and just to feed the number in his device. What do you give the patient? You said we give the patient special tool. What is this tool you give it to him?
Yes, exactly as you said. So the patient receives a blood pressure monitor with a cuff, and also can receive a weight scale, and both of them are Bluetooth enabled. So if the patient is compliant, then the readings from these two devices are collected by the communicator that we give with the latitude system to the patient. So if it's a compliant patient, then they can stand on the weight scale every day at the same time, and they can take the blood pressure every day at the same time. So then the communicator will collect all the measurements, and it will transfer to the cloud. So you can sit in front of your laptop anywhere in the world where you have internet connection, and you can simply read all these trends, and you can check everything from the patient's device anywhere in the world. So this is how our remote patient monitoring system works.
Okay, thank you very much. We can go to the next part of the presentation.
Yeah, thank you. So this was all about the heart failure diagnostics. And the next part, I was asked to tell you a few things about the SICD. I'm not sure if you are all aware or familiar with our subcutaneous ICD, but it's important to know that this is unique to Boston Scientific, and it's a really great device that we have been using for many years now in many countries. So I just wanted to give you just a very high-level overview, because of course there are many things to discuss about SICD, but just to give you an idea how the system was developed and how the system works. So just a little bit of historical background. So the proof of concept was done in 2002 with the SICD. Then the IDE trial started in 2008. Then the first generation of SICD went on the market in 2009. So again, you can see that we have more than a decade of clinical experience with the device. Then in 2012, Boston Scientific acquired Cameron Health, the company that developed the SICD. Then in 2015, Boston Scientific came out with the second generation device, which became smaller, thinner, but longer lasting due to our EnduraLife battery technology. So the same battery technology is implemented in the SICD that I told you about before. And it's also latitude compatible. So the SICD is also compatible with our remote patient monitoring system. Then the third generation came out in 2016. And since then, we had also some other developments, such as things in the implant technique and some of the implant tools, and some new things in the labeling of the device. And the nice thing, that this is also nice up until now, but what is even nicer is the future. So in the future, for the future, we are talking about the MCRM, which stands for the modular CRM approach, where you can combine our SICD system with our future Empower. The name is Empower leadless pacemaker. So for your information, we are already running the clinical trial in which we are recruiting patients who receive an SICD and the concomitant leadless pacemaker. So the two devices are able to communicate with each other. And for example, if you have a patient today who is indicated for ICD, and if you implant an SICD, and because the SICD cannot provide pacing, but if your patient develops, let's say, in 10 years, a brady pacing need, you can simply add a leadless pacemaker, and you saved the vasculature and the heart of the patients for those 10 years. Because the big point of the SICD is that with implanting the SICD, you can avoid all the complications and all the risk that you implant with a transvenous system. because we leave all the heart and all the vasculature completely untouched, because the SICD system stays outside of the chest. So this is the beauty of the whole concept. And in the future, you will see the MCRM or modular CRM approach. And just for your information, we already have more than 100,000 patients implanted with SICD worldwide. So let's see just a very, very short summary how the system looks like and how the system is implanted. So with the SICD, we have the can and one lead. So the system works with only one lead. The device is implanted on the left side of the chest of the patient, and the lead is tunneled up along the sternum outside of the chest again. So it's very important that nothing goes into the chest and into the vasculature. And the device can perform sensing along three different sensing vectors, which are the following. The first one is the primary, which is between the can and the proximal sensing electrode of the lead. The second one is the secondary sensing vector, which is between the can and the distal sensing electrode of the lead. And the third one is the alternate, which is between the two sensing electrodes of the lead. So this is how the system works. The system can sense along these three sensing vectors. Let's see how the system works from an algorithm perspective. This is just a very, very simple overview. So the device is much, much more complicated in the algorithms. It's a very, very smart device. So there are many, many algorithms running in the device, but the use of the device is very simple. So just for information, there are three phases that the device is using within the Insight algorithm architecture. Insight is the name of the algorithm of the SICD that is used for sensing and therapy decision. So in the first phase, the device is sensing the subcutaneous signals, which are quite similar to a surface ECG, as you can see here, and it's quite different from an intracardiac signal. So the device, the SICD needs special algorithms for this to analyze the subcutaneous ECG. In the second phase, the heart rate is determined, and for that, the device is using 4 different double detection algorithms in order to reduce oversensing. Again, this is a very complex process, but this is just a quick overview or a highlight of how the device works. In the third step or the third phase, the device is making the therapy decision whether it should deliver therapy or not. So here the heart rate is assessed and the therapy is confirmed. And here the device is using 3 different rhythm discriminator algorithms in order to confirm therapy. And basically that was all about the SICD system itself. I'm happy to answer any questions if you have. In the next presentation, I will present to you the latest clinical data about the SICD.
Regarding the subcutaneous ICD, I read about the possibility of pacing. Was it tried and did not work?
So the SICD, yeah, very good question. The SICD can provide pacing, but only post-shock pacing up to 30 seconds after shock has been delivered. But no continuous pacing can be delivered by the SICD.
Okay, so what I read was about the pacing post-shock.
Yes, correct. It's only post-shock pacing that the device can deliver up to 30 seconds.
Okay. But till now, no anti-tachycardia pacing, sir, right?
No. But again, once we come out with our Empower device, then the Empower leadless pacemaker will be able to provide both bradycardia pacing and ATP if needed.
Okay, so Dr. Ahmed Abdelmenem is asking a question in the chat.
Yes.
should we do defibrillation threshold testing with the subcutaneous ICD?
Yes, this is recommended. So this is the recommendation of the company, and we indeed perform a DFT test for each implant. Yes. But for your information,
we can go to the next presentation.
There is a study running, and
yes.
It's run by Dr. Knops from Amsterdam, from the Netherlands, which is called the Praetorian DFT study, where they investigate whether the DFT testing can be eliminated or not. Like, in case of transvenous devices, when we had the simple study, yes. Where they proved that DFT test was not needed. And nowadays, most of the physicians don't perform DFT test.
Yes. Okay,
please let me know if you see my next slide. I'm already sharing it.
Your beautiful purple slides.
Great. I'm trying to go into full screen mode. I hope it will work now.
You look, no, not this one. Look, if you can go back. Go back.
Just give me a second. I'm trying to.
Okay, if you can run from the lower button, which says slide 1 to 17, push.
Yeah, but unfortunately, I see different user interface, so I don't see those buttons, unfortunately. So let me try to
go back to the same screen.
Yeah, I'm trying. Just I don't see the same buttons that I used to see in the beginning. What do you see now?
I can see your two. Now, but.
Can you see it in full screen?
Yes,
mode?
Yes, full screen.
Okay, great. So I hope it will work now. So in the first part, I will talk to you about the Praetorian and the untouched trials. And the result of these two trials were announced in 2020 at HRS in the United States. Can you see my next slide?
Yes.
Okay, great. Okay, so it works. So just again, just a very high level overview, because there are many more details, but we don't have time to go into all those details. So I just wanted to give you a flavor about these studies. So the Praetorian study was a very, very important study for the SICD therapy, because this was the very first prospective randomized head-to-head clinical trial, which compared the performance of SICD versus transvenous ICD. It was an investigator-sponsored research, also run by Dr. Knops from Amsterdam. And in the study, they enrolled almost 850 patients, and they randomized them into two arms in a one-to-one fashion. And these were the enrollment criteria. And there were 39 sites in 6 countries, both in the EU and US. So here you can see the study design. So as I said before, the patients were randomized into two arms, the SICD and the transvenous ICD arms, and the patients were enrolled who had a class 1 or class 2A indication for ICD without a need for bradycardia pacing or ATP or CRT pacing. There was a median follow-up for 4 years, and the primary endpoint of the study was non-inferiority when it comes to complications and inappropriate shock rates. And the results were announced at HRS in 2020. And the primary outcome was that they were able to prove non-inferiority for the SICD. So the SICD had comparable performance to transvenous ICDs, but as mentioned before, with the SICD, you are able to avoid all the complications, serious lead-related complications that you normally implant with a transvenous system. And of course, you can imagine that it's very important for younger patients, but of course, every ICD indicated the patient. So it confirmed that SICD can be the preferred choice for most of the ICD indicated patients without a need for pacing. Here you can see on the right-hand side that the primary composite endpoint was similar in both arms. So what about lead-related complications? Again, it's I think it's very self-explaining or explanatory that the SICD was doing much better in terms of serious lead-related complications. So you can you can see more than 4 times as many patients experiencing lead complications in the transvenous ICD arm. There was another study that was also an investigator-sponsored research run by some other physicians, which was the untouched study. It was announced; the results were announced at the same time. So, in the untouched study, they investigated the Emblem and Emblem MRI SICD systems. So, these are the 2 latest generations of the SICD, and they found a very low inappropriate shock rate with the SICD. Here on the left-hand side, you can see the inappropriate shock rate in studies with transvenous ICDs, and with the purple bars, you can see the results from the untouched study with the SICD. So the main message here is that the SICD is comparable to the transvenous ICDs, or doing even better when it comes to inappropriate shock rates. And as a conclusion from the Praetorian and the untouched study, so if we look at the results of these 2 studies, we see that from the Praetorian study, we see that the SICD demonstrated that it has a comparable performance to transvenous ICD, despite primarily they included older SICD devices and implant techniques. It's important to mention because the study started in 2012, if I'm not mistaken. So back at that time, we still had the first generation of the SICD, and since then we had many developments in the software and also in the battery technology and also in the implant technique. So what we do today is a much better way to do it than we did it back at that time. So despite this, the SICD had significantly fewer lead-related complications in the Praetorian study, and there were fewer serious infections that required extraction. You can see the numbers here in the brackets. And trend in fewer overall complications are likely to be significantly lower at the 8-year follow-up. So for information, the Praetorian patients are still followed up and up to 8 years, and the results will be published with the Praetorian XL study in a few years. The untouched study demonstrated that patients with the latest generation of the SICD with the SmartPass algorithm, just for information, the SmartPass algorithm significantly decreased T-wave oversensing and other type of cardiac oversensing. So with these devices, they found a 2.4% rate of inappropriate shocks at 1-year follow-up, which is as low or even lower than the transvenous ICD data. So again, these 2 studies confirmed that the SICD can be a good option for all ICD indicated patients who don't have a pacing need. So these were from 2020, and the latest, the most fresh data from the SICD world is the Atlas trial, the results of which were announced last year in 2022. And this trial showed for the first time superiority of the SICD in a head-to-head randomized prospective study. So the Atlas trial was again an investigator-sponsored study, and it was run in Canada by Dr. Jeff Healy in 14 different centers. So into the study, they enrolled patients with a primary or secondary ICD indication who were at increased risk for lead-related complications. All the patients had to pass SICD screening because, for information, the SICD implant needs a prior screening, which is a very simple way of determining if a patient is eligible for an SICD or not. It's a very simple method. And these patients were randomized in a 1-to-1 fashion in 2 arms. The first arm was the SICD arm. The other one was the transvenous ICD arm. and they were looking at safety outcome at 6 months. So they were looking at composite of all perioperative lead-related complications, and you can read all these complications that they looked at 6 months below that sentence. So these are all the serious lead-related complications that they were looking at. And if you look at the results, what they found in the ATLAS trial, they found that 92% fewer serious lead-related complications were present for the SICD patients, and there were 0 cases of the following. So you can read these complications, of which there were 0 cases in the SICD arm. So you can see that the composite primary outcome measured at 6 months was 1 for the SICD arm and 12 for the transvenous ICD arm. You can read here the different complications that were found in both arms. So again, it shows that with the SICD, you can avoid most of these serious lead-related complications. And here you can see just a quick summary that with the SICD, they saw a 92% reduction in serious lead-related complications when compared to the transvenous ICD arm in the ATLAS trial. When it comes to shock efficacy, they found that in both arms there was a shock efficacy over 99% in both arms. And as you can see, the final shock efficacy was very similar in both arms. So it means that both devices are very safe for the patients. Another thing, what they found in the study is regarding the secondary outcomes. So here you can see the cause of inappropriate shocks. If you look at the left-hand side of the slide, you can see that there was a 82% less likelihood in the SICD arm for inappropriate shocks due to atrial arrhythmia. So when it comes to inappropriate shocks due to atrial arrhythmias, the SICD is doing much better than any transvenous ICD, because it's important that in this study, any kind of transvenous ICD was allowed to enroll. And when it comes to inappropriate shocks due to T-wave oversensing or EMI, they found that the transvenous ICDs were doing better, but it's important to mention here and to highlight what you can read in the blue part, that the primary cause for inappropriate shocks for SICD was T-wave oversending as an EMI, but 80% of EMI was due to TENS units. These are, the neurostimulator units that the patients use. So those are absolutely not recommended for any ICD patients, not just for the SICD. Here is an overview of the inappropriate shocks rates that have been seen in different studies. On the left-hand side, in purple or dark blue bars, you can see the earlier SICD studies. So you can see that there were higher inappropriate shock rates in the beginning. And this is because I told you before that there have been many improvements in the SICD, the device itself and the algorithms, and also to the implant technique. So that's why we see a significant drop over the time as you look at the dates of the different studies. And with the latest clinical data, you can see that with the emblem devices, so the latest devices, we can see very low inappropriate shock rates, which are absolutely comparable to the transvenous ICD clinical findings. So again, as a summary, just to sum up everything, in the Atlas SICD trials, the investigators found a 92% reduction in serious lead-related complications when it comes to the comparison of transvenous ICDs and subcutaneous ICDs, and it was in favor of the SICD. And in the Praetorian study, they found, so it was at 6 months. It's also important to mention. And in the Praetorian study at 4 years, they found a 79% less risk for serious lead-related complications in the SICD arm when compared to the transvenous ICD. So just a summary of all what I have said so far. So data from the ATLAS and the Praetorian randomized controlled trials demonstrate that the SICD is now superior to transvenous ICD in preventing the serious lead complications which are associated with invasive leads that the transvenous systems are using. Because we all know that the lead is always the weakest link of any transvenous system, even if it's the most reliable lead in the market. And the proven superiority of SICD in preventing these serious lead-related complications occur as early as 6 months after an implant in adults of all ages with the most common ICD indications. So it's very important that even after 6 months, you can see significant decrease in these complications. And of course, if we go over the time, and you will see it hopefully in the Praetorian XL study, that after many years or more years, we know that lead complications, many of them are coming later over the time. So we expect that we will see even higher decrease in these complications in case of the SICD. And we also know that the SICD has demonstrated shock efficacy between 98 and 100%, which is comparable to the transvenous ICDs. And we saw it in 6 different prospective randomized studies, and with almost 5,000 patients and some registries over 10 plus years. And patients with the SmartPass enabled emblem devices. Again, SmartPass is a development in the SICD. It's an algorithm or filter that helps preventing inappropriate shocks due to T-wave oversensing, for example. So with these devices, the inappropriate shock rate is as low or even lower than transvenous ICDs, especially in patients at risk for atrial arrhythmias. And there is sufficient clinical evidence that patients of all ages without a pacing indication should be made aware of the SICD as an option during the ICD shared decision-making discussion. Of course, I know very well that the SICD is not yet available in every country, but hopefully it will be soon in all our countries. And that was the last slide from my presentation.
Thank you very much. We have a question from Dr. Ahmed Abdelmanan regarding the heart failure logic. All the he's asking, are all the options of heart failure logic applicable or present or incorporated in the subcutaneous ICD?
No, they are not. They are only available in the transvenous devices of ours.
Okay, thank you very much. Any questions from the audience? Please unmute your microphone and ask the questions. Ahmed Gamal, Dr. Azza, Bahir, Iman Qasim, Iman Samir, Fatma, Hemmat, Rolos, Lubna, Mansour, Muhammad Hamdi, Muhammad Sami, Rahab Hamdi, Riham, Sally Magdi, Suhail. No question. Thank you very much. That was very nice presentation, very informative, very logic. Actually, we have to re-listen to it so that we can apply it in our programmers and in our devices in order to use the utmost technology for each patient. We hope this technology will come to us very soon. Thank you very much, Boston, shukran Sabri. Thank you, Sabri, for joining us
Most welcome.
this evening. Okay,
and of
now
course,
we
if
move
you have,
to Medtronic.
Sorry, if you have any questions in the
Right.
future, we are always happy to give you any presentation on anything. So just please let our colleagues know in Egypt, and we will manage, or we can organize.
Actually, I want you to give us we can schedule this a presentation about how to use the maximum of programming of a dual chamber pacemaker and a CRT.
Sure, we can work on that.
Yes, to listen to the features, because sometimes I am with the patient, I see many features, I don't know how to go inside and see and look, especially when you are in the clinic. But if we learn and study them while you are sitting, watching and kida, we can apply them easily in the clinic. So we need another session.
Please. Can I ask a simple question? أنا ريهام يا دكتورة مريم.
Yes. يلا ريهام.
Can I ask simple questions?
Yes.
If the patient requires pacing after surgical ICD was implanted, can we? What will we do to that patient?
ما قال لك pacing after ICD subcutaneous ICD?
Yes. لو عيان بعد ما ركبنا له لقينا ان هو يعني حصل له اي اندكشن اي بلوك فاضطرينا نركب له ICD، ساعتها السيرجيكال ICD مش هيشتغل كبيسنج.
اسمه subcutaneous يا اختي. اسمه subcutaneous.
انا قصدي subcutaneous ICD مش فور بيسنج. هو اللي فهمته ان هو فور بيسنج فور 30 سكند بعد بس بعد الشوك.
ماشي صح.
It's post-shock pacing for 30 seconds or 30 seconds only.
Okay.
لو عيان ريكوير بقى لايف لونج بيسنج بعد كده.
خلاص يا ريهام.
Yes,
the question is, if a patient needs pacing after he receives his subcutaneous ICD at any point of time, is there contradiction between implanting a regular pacemaker and this ICD? Is there any interference with the pacing spikes with this ICD or not? Please answer.
Well, it's possible. So we know cases when the patient already had a pacemaker and for this or that reason they couldn't implant or they didn't want to implant a transvenous ICD. So they added an SICD. So it's possible, but in that case, the screening for the SICD needs to be done very carefully because, of course, we don't want to have any oversensing or undersensing or any sensing issues. It's possible, but you need to take special care in that case.
So special care with the implantation of the SICD if the patient has a pacemaker, but if after implanting subcutaneous ICD, he needed a dual chamber pacemaker for pacing. What are you going to do?
Yeah, it's a good question. So again, special care needs to be taken not to have any oversensing, or ultimately, if there's no other way, then you can still, remove the SICD and add a transvenous system, and you still gained several years for the patient, with an intact vasculature and heart. So that's also an option for younger patients because we know that the pacing need in ICD-indicated patients is very, very low at the time of indication. Of course, if a patient already has an indication for pacing, then SICD is not the device for them. But if the patient, for example, you implant an SICD today and the patient develops pacing need in, 5, 7, 10 years, then you can still, if there's no other option, but as I said, in the next few years, we will have the leadless pacemaker, which will communicate with the SICD. So that will be one option. But if, for example, if it's not available or for any reason you cannot implant that, you can still implant a transvenous system and you still saved the patient for 10 years from any transvenous complications.
Okay, thank you. Another question from Dr. Rahab Hamdi. Does subcutaneous ICD have the same MRI أول حاجة MRI capabilities اللي هي MRI compatibility like the regular transvenous ICDs?
Yeah, so the SICD is also MRI conditional up to 1.5 Tesla. So you can send an SICD patient to MRI. Of course, you have to program the device into MRI protection mode like every other transvenous device. It has an MRI protection mode as well. And then you can send the device into MRI environment.
Should we wait for some time, like when we wait for 3 months after implanting an ICD before going to
Yeah.
MRI or no?
Yeah, so there are certain conditions, so that's why it's we say it's conditional, not compatible. So it's conditional. It's like every company has some conditions for the MRI scan. But the good news is that with the Boston Scientific devices, so both SICD and transvenous devices, we don't have any exclusion zones in the body. So you can perform an MRI in any part of the patient's body. And we don't have time limitations like some other companies have. We don't, so you can perform even complex MRI scans that need more time. You just have to program the device into the MRI protection mode. But it's possible.
Okay, thank you very much again. Yeah, very nice discussion. Okay.
Thank you very much for the opportunity. It was nice to talk to you.
Yeah, thank you very much. Thank you very much. The next speaker is Lubna from Medtronic. Ahmed Gamal. Yes, Lubna, please share your slides.
Okay. Thank you, Dr. Mirvat. Thank you so much for having us. It is a great opportunity صراحة، ويعني أنا دي أول مرة أحضرها، و I regret إن ما حضرتش حاجات قبل كده. It's very informative. السيشن النهارده هو actually إحنا كنا حابين نعمل السيشن على المايكرو programming deep details، بس unfortunately بسبب إن هو حد will present it from Dubai، فالوقت بالنسبة له متأخر فهي couldn't do it. فالنهارده أنا هدي يعني البرزنتيشن، هقول البرزنتيشن على حاجات already كانت موجودة في Medtronic، و I will add topics على products إما launched or will be launched in the very near future خلال 3 شهور إن شاء الله في مصر. فالأجندة هتكون على ال Select Secure Criteria Update، على الميترونيك ICDs، هتكلم على Smart Chip Technology وال ATP during before charging وال VZAF، وعلى ميترونيك CRT هتكلم على Ensure CRT3 والأدابتيف والأوبتيفول والفيكتور إكسبريس 2 والأتين ستابيليتي كواد ليد اللي it is already launched يعني recently في مصر والريفيلينج. طبعا حضراتكم عارفين إن ميترونيك launched ال Select Secure، وخدت first company to be branded or approved with CE mark for S bundle basing. What's new على ال Select Secure Lead. ال Select Secure Lead 17 أكتوبر 22 خد FDA approval على ال natural conduction system. فميترونيك extended the criteria to use ال lead على ال left bundle plus ال his bundle basing دلوقتي. That's why in all our trainings now we focus not only على his bundle actually على conduction system basing. وطبعا حضراتكم عارفين ان ال left bundle success rate فيه اعلى من ال his bundle. Okay. When it comes to TACI or ICDs Medtronic، حاجة هي already احنا بنستخدمها for years، بس actually we see that some physicians underutilize the usage of the smart shop technology، أو أحيانا they turn it off. السمارت شوب تكنولوجي هي بتعلي أو بتعمل reduction of inappropriate shocks. We all know that the shocks are classified into 3 groups: appropriate, inappropriate, unnecessary. So when it comes in inappropriate shocks, we have a solution that's called smart technology. هو عبارة عن 6 exclusive algorithms to discriminate between the true lethal ventricular arrhythmia from other arrhythmic and non-arrhythmic events. الارrhythmic events like SVT والnon-sustained VT والatrial fibrillation، عندنا الويفلت والPR logic والconfirmation plus، and I will go through each of them quickly. والnon-arrhythmic هو زي الoversensing والnoise. We have T-wave discrimination والlead integrity suite اللي هو integrity alert والlead noise discrimination. All the features, all the algorithms are nominally on, and we should keep them on unless the physician has a preference in how one of them to be turned off. First الwavelet it's just يعني very quick revision عليه. الwavelet هو EGM morphology بيعتمد على المورفولوجي of the rhythm. ففي بداية الإمبلانتيشن بناخد template من الناتشرال نورمال أو الانترنسيك نورمال ريذم we stored as a template as a reference. Then لما بيكون في ventricular arrhythmia أو any kind of arrhythmia ناخد 8 beats من الاريزميا دي and we compare to the stored template. The stored template لو ال 8 beats 3 out of 8 matched the threshold of 70% to the stored template, then the arrhythmia is classified as wavelet and the therapy is aborted. The shock is aborted. زي ما حضراتكم شايفين هنا في البروجرامينج ال 8 بيتس and الماتشنج بتاعهم للستورد template. And this arrhythmia is classified as SVT. That's why the shock is aborted. طيب ال PR logic الwavelet موجود في كل الديفايسز single or dual or triple. عندنا ال PR logic هو موجود في الدول والتريبل بس بيعتمد على evaluation على ال components of the rhythm زي الريت سرعته إذا كان جوه الديتكشن زون the regularity إذا كان regular or irregular الباترن هو ال number of P waves to R waves ال AV dissociation وهنا ال AV dissociation هو بيشوف البيتس وبيشوف إذا كان 4 من 8 beats لو كان في VV interval without atrial activity, then it's considered 4 beats out of 8 beats without atrial activity, then it's considered dissociation. Our AV interval is different from the previous intervals by 40 milliseconds. Then we have AF evidence is another component the algorithm evaluates according. AF evidence إن هو بيكون في definitely atrial activity سريعة with irregular response من ventricle وعندنا آخر parameter أو آخر components هو presence or absence of the far field R wave اللي هو بيشوف over sensing في الاتريوم. According to these components الالجوريثم بيعمل classification. أول classification إنه يكون الريذم الاريزميا atrial fibrillation أو atrial flutter وده usually بيكون في high activity من الاتريال أو high rate of atrial then plus irregular ventricular response أو 2-to-1 conduction or 3-to-1 conduction and so on is classified as atrial flutter or atrial fibrillation. Sinus stack بيكون 1-to-1 atrial to ventricle وفي gradual increase until إن الريذم أو الأريزميا بتدخل الديتكشن زون. once we have a gradual increase, it's classified as sinus stack. Other 1-to-1 SVTs اللي هي زي الjunctional rhythms والدبل tachycardia آخر classification هو لما بيكون في supraventricular مع ventricular tachyarrhythmia مع بعض. It's combined. ده كان PR logic. ثالث algorithm هو confirmation plus. Confirmation plus هو automatic algorithm. We don't use to do anything regarding confirmation plus. هو simply لما بيحصل detection للVT zone. sorry detection للأريزميا.
يلا مريم. يلا.
The device starts to charge the capacitor. Once it starts to charge the capacitor بيدي ال ATP therapy. طيب. لما بيدي ال ATP therapy بيرجع تاني يعمل redetection للأريزميا. If it's terminated the therapy is aborted. لو الأريزميا is not terminated the therapy أو الشوك بندي الشوك. This is the confirmation plus. confirmation plus البنفيت بتاعته الأساسية إن ما نديش unnecessary shock. لأن لو هي terminated بال ATP you don't need to deliver a shock and waste the charge. رابع الجوريثم هو التي ويف ديسكريمينيشن. التي ويف ديسكريمينيشن يعني بيwithhold الثيرابي لما بيديتكت ان في تي ويف اوفر سنسنج. بيعرف ازاي ان في تي ويف اوفر سنسنج في الالجوريثم ده عن طريق حاجه اسمها الار تي باترن. الار تي باترن ار تي ريكوجنيشن بيشوف ان one amplitude is high, one R wave is high, and then the next R wave is lower, then high, then low. This is called RT pattern. Once this pattern is recognized بياخد آخر 6 beats، بياخد أعلى 3 amplitudes وبيعمل average. تحت الافريج ده بيعتبره تي ويف وبيignored. التي ويف discrimination بتwithhold الثيرابي لو it's considered أو recognized إن في تي ويف اوفر سنسنج، لكن هي مش حل للتي ويف اوفر سنسنج definitely، بس هو حل إن هو ما بيديش شوك على التي ويف اوفر سنسنج. آخر حاجة هو lead integrity في السمارت شوك تكنولوجي، هو lead integrity suite، عبارة عن lead integrity alert لما بيكون في lead fracture، وده يعني بيبقى recognized لما بيكون في non-sustained VTs على high rate أو high impedance unexpected high impedance، بيدي alert وبيextend ال VF detection time. والlead noise discrimination، وده algorithm مهم جدا لأن لما بيكون عندنا في مشكلة في يعني الليد بيديتكت noise، بيcompare الفار فيلد للنير فيلد. لو same reflection أو same deflection من النير فيلد للفار فيلد then it's considered a true arrhythmia. لو ما فيش نفس الديفلكشن على التو far field والفار أو النير فيلد it's considered noise. كل الالجوريثمز دي 6 الجوريثمز السمارت شوك تكنولوجي احنا بنقول ان هم one of the best algorithms علشان to يعني decrease inappropriate shocks. طب في study اتعملت كان اسمها pain free SST، دخل فيها 1900 patient، هي اتعملت for 2 years. at 1 year follow up كان inappropriate shock percentage للdual والtriple chamber patients كان 1.5 و 2.5% للsingle chamber patients at 1 year. Okay. Smart shock technology is a solution to decrease the inappropriate shock. How to decrease the unnecessary shock عن طريق ال ATP during charging, and I believe in Medtronic is the only company have the mechanism to change between ATP during charging and ATP before charging. ال ATP during charging هو is a way to decrease the unnecessary shock. The shock can be terminated with a painless therapy without giving a shock, without delivering a shock. ATP during charging once in في detection لل VT أو الarrhythmia, the device starts to charge, the capacitor starts to charge. بيدي one run of the ATP. If this run is successful, then be aborted therapy. لو this run of ATP is not successful, we deliver الشوك. This is ATP during the charging. طيب في ATP before the charging هي عبارة عن إحنا بندي one round من ATP. لو هي successful خلاص مش بيبدأ يcharge الكاباسيتور. لو هي مش successful ATP بيدي another round من ATP ويبدأ يcharge الكاباسيتور. وظيفة ال ATP before charging لأن حضراتكم عارفين إن أصلاً once إن الكاباسيتور started to charge هو بيكوست الباتري around 10 to 20 days من التشارج. فلو البيشنت التايب اوف arrhythmia اللي بيجيله can be terminated with ATP, it's way better إن إحنا نستخدم ال ATP. طب لو ال arrhythmia is aggressive و should be shocked directly without delay من الثيرابي بنستخدم ال ATP before charging. Sorry, during the charging. بس you don't need to manipulate this algorithm لأن هي أصلاً adaptive وبتتغير لوحدها. It starts مع ال ATP during the charging. لو في consecutive runs of ATP success ودي this is programmable، تقدروا تغيروها. مثلاً 3 rounds of ATP ورا بعض successful بيتحول على طول ل ATP before charging عشان يتشارج يعني يسيب الانرجي. طيب لو في two consecutive ATP failures بيتحول directly ل ATP during charge. فهي automatic و adaptive to designed to save the battery without risk of delayed hard voltage therapy. I believe Medtronic is the only company and definitely other companies عندهم ATP before charging or during charging بس mechanism to switch between the two algorithms يعني Medtronic بس اللي عندها this option. في guidelines recent guidelines 2019 was released by HRS على ال ICD programming. ال ICD programming يعني these guidelines قالت إن Medtronic ICDs و CRTDs are nearly identical to the guidelines. The nominal parameters are identical to the guidelines except for 3 programming changes. وهما إن ال VT NID to be 24 instead of the 16 وال ATP before charging تبقى بدل during charging وال RB lead noise تبقى on without time out وهي النومينال بتاعها إن هي with time out 45 seconds. These are the only 3 parameters that should be changed to be identical to the guidelines. يعني if we want to stick to the guidelines, you don't need to play with the nominal parameters that are set في ال devices at implantation. في device هو it will be registered في مصر خلال 2 months تقريبا هو الفيزيا AF. الفيزيا AF هو single chamber ICD بس with a traditional lead. We don't use a special lead to monitor closely and diagnose atrial fibrillation patients. الفيزيا AF بيستخدم or appropriate للpatients اللي at risk of developing atrial fibrillation واللي عندهم palpitations و symptomatic AF واللي you need to closely monitor AF burden علشان to assess إذا كان the medical treatment is necessary or should be adjusted. يعني simply إن الفيزيا AF هو عبارة عن إيفارا hardware device hardware مع software to detect atrial fibrillation. We can call it Ivera with loop recorder installed built-in فيها. الديتكشن algorithm هو إن الديفايس بيقيس ال RR variabilities interval variabilities بيحطها على اللورنز بلوت. لو normal sinus rhythm في اللورنز بلوت بتظهر بالشكل ده very consistent or ثابتة. لو في atrial fibrillation بتظهر إن في high rate of RR interval variabilities. الفيزيا EF يعني هو مميز إن هو في high rate of detection للatrial fibrillation. ف 95% we say 95% of the burden of AF is captured. لما يكون في 100 hours of AF 95% of these hours will be detected. 95% of the episodes detected as well. فهو يعني you can use it to monitor closely the atrial fibrillation. Okay. When it comes to Medtronic CRT, عندنا Ensure CRT Suite هو ال Complete Capture Management والatrial tracking recovery ventricular sense response conducted AF response والcardio sync in office optimization. طيب ال Complete Capture Management هو بس يعني very quick revision لأن احنا يعني زمايلي في التكنيكال سبورت كانوا بيقولوا لي إن في still دكاترة بتيجي في الفولو اب they need to test every time ال threshold في كل follow up و they're not convinced بالautomatic أو complete capture management. complete capture management is 100% safe لأن هو بيقيس on daily basis الثريشولد، بيظبط الامبليتيود according على الثريشولد بالسيفتي مارجنز يعني اما نومينال يا اما حضراتكم بتظبطوه. فده يعني it makes sure ان ال pacing outputs remains at safe levels while actively managing the battery current drain. طيب الثلاثه algorithms دول ال VSR وال conducted AF response وال atrial tract recovery مهمين في ان احنا ان دول بيحافظوا على ان to increase the percentage of patients with less than 90% by V pacing. طيب ventricular sense response conducted AF response طبعا زي حضراتكم عارفين ان during atrial fibrillation بيكون في irregular response من الventricle. in order to have a good CRT responder patient محتاجين نعمل normalization أو يعني regularization للresponse بتاع الventricle during AF. فالconducted AF response بيعمل إن هو لو البيت بتنتهي بVS بيزود بيoverride البيسنج أو بيزود البيسنج 1 beat per minute. لو البيت بتنتهي بV بيس بيقلل الريت بيسنج ريت ب 2 beat per minute. ده بيعمل ايه؟ بيعمل زي normalization كده او regularization للventricular rate during الAF، فبيحسن percentage of biventricular pacing وما بيأثرش على المين ventricular pacing rate. Conducted AF response is nominally on. الventricular sense response هو يعني during أكيد الventricular atrial fibrillation أو إن إحنا عشان نوصل high rate of by V pacing لأن طبعا البيشنت is not considered a good responder للCRT مش بياخد الماكسيمم بنفيت والكارديك اوتبوت لما بيكون الباي في بيسنج اقل من 90%. فالفنتريكولار سينس ريسبونس بيميك شور ان الباي في بيسنج او الفنتريكولار بيسنج اعلى من 90%. فونس ان الديفايس حس في سنس بيدي immediately في بيس. It's not a true by V basing 100% definitely، بس خلال الاستاديز على 8000 patient يعني extracted من الميترونيك داتابيز الكيرلينك داتابيز لقوا ان ال VSR بتحسن الكاردياك performance versus no CRT at all. Definitely by V basing أفضل outcome then ال VSR definitely better than ال CRT. sorry ال CRT ما يكونش شغال خالص. فبليز keep the VSR on all the time. Okay. الكارديو سينك هو in office test. in office test بنشوف فيه optimal AV و VV programming. هو يعتبر alternative أو حاجة تكونفيرم الإيكو results. فلو حضرتك عايز تظبط ال AV وال VV programming then you can use the CardioSync test. sorry كنت حاطة بس هنا هنا. it's a very simple test. بنحط فيه بس ال sensing lower rate وال pacing lower rate then we press start. in 1 minute هيجي لحضرتك ال pacing configuration وال VV pace delay وال pace AV وال sensed AV. These are the recommended values. you can يعني use it as alternative للإيكو أو مع الإيكو to confirm. Any question؟ أنا عارفة إن هي quick revisions على الحاجات الرادية عندنا.
معلش ممكن سؤال، هو الكارديو سينك ده موجود في انهي اجهزه من اول انهي فيرجنز من CRT؟
هو موجود في كل الفيرجنز من يعني من اول البروتكتا.
تمام.
فالراديو بروتكتور فيزد اوت، فهو موجود في كل الديفايسز اللي موجوده في مصر من 6 سنين من اول البروتكتا.
شكرا.
دكتور احمد معلش، مساء الخير. حمدي، محمد حمدي، تكنيكال سبورت في ميدترونيك. هو الفيتشر دي موجوده في CRT-B وCRT-B، كل الموجوده دلوقتي، كل اللي احنا بنكتبه حاليا موجودين فيه.
بالظبط، هي موجوده يعني من اول الديفايسز اللي نزل لاكثر من 6 سنين، فهي موجوده حتى من الديفايسز الفيزد اوت، هي اوريدي كانت موجوده. بس هي يعني زي ما قلت لحضراتكم، انا بحاول بس اقول الفيتشرز ان احنا we feel that these features are underutilized في مصر، رغم ان هي يعني في ليها clinical و outcome benefit، وهي مستخدمه بره بقوه يعني.
تمام، شكرا.
الادابتيف CRT one of the most underutilized feature انا شفتها موجوده في مصر، بس هي موجوده بره في لدرجه ان في بعض الكونتريز مش بتاخد CRT من ميدترونيك unless ان هو يكون adaptive. طيب الفكره في بس انا عندي مشكله في سوري. الفكره في الادابتيف CRT ان احنا we have two types of adaptive CRT or adaptive algorithms. one الادابتيف LV pacing. فكره الادابتيف LV pacing ان usually البيشنت بيكون عنده left bundle branch block، بيكون الار في يعني الانترنسيك ار في سليم. ف why to correct something while it is already normal؟ فهو بيعمل ايه؟ بيعمل انه بيسيب الار في يشتغل، وبيعمل بري بيسنج في الليفت ventricle. بيعمل بري بيسنج في الليفت ventricle according to measurements بتتحسب كل دقيقه. فكل دقيقه بيشوف البي ويف، QRS width، والاس اي في والبي اي في، وبيعمل كالكوليشن ويشوف امتى هيدي بري بيسنج في ال في تو سينكرونايز مع الانترنسيك ار في كوندكشن. فالادابتيف ال في بتشتغل امتى؟ بتشتغل لما يكون في انتاكت اي في كوندكشن، ولما بيكون الهارت ريت اقل من 100 بيت بير مينت. اوكي، طيب بيسويتش احيانا الادابتيف باي في، او you can program it لادابتيف باي في. ادابتيف باي في هو بيعمل اوتوماتيك اوبتمايزيشن ما بين الاي في والفي في ديلي again كل دقيقه based on the change in patient activity levels and conduction status. فلو البيشنت على هاي ريت او الفنتريكولار ريت اعلى من 100 بيت بير مينت، او في loss of AV conduction، بيتحول immediately على adaptive باي في بيسنج. طيب ايه فايده الادابتيف اصلا؟ الادابتيف بيقلل الهارت فيلير هوسبيتاليزيشن، كمان هو بيزود الريسبونس ريت للسي ار تي، الريسبونس للسي ار تي او الريسبوندرز 12%. ليه بيزود الريسبوندرز 12%؟ لان اولا احنا بنعمل سينكرونايزيشن بري بيسنج للال في مع الار في، كل دقيقه بنراجع الاي في ديلي والفي في ديلي، نعمل calculations كل دقيقة. تاني حاجة إن هو بيريديوس الريسك of atrial fibrillation by 40%. لأن definitely زي ما حضراتكم عارفين ال unnecessary RV pacing هو one of the main contributor لل AF. فonce إن إحنا قللنا ال unnecessary RV pacing اللي إحنا we don't pace في ال RV، هو ده بيبقى سبب إنه بيخلي فيه 46% reduction في ال AF risk for all patients. Okay. في recently كان في study على المورتاليتي. I didn't want to include it صراحة، بس كان بيلينك الادابتيف بالمورتاليتي ريت. إن إزاي بيحسن المورتاليتي ريت، حسنها بنسبة 9%. ده كان على سنتين. أوكي. في أي سؤال على الادابتيف؟
اطلع اتنين بس. لحظه يا دكتور، كان دكتور ادم بيسال بس معانا الفنتريكولار سنس ريسبونس. دكتور ادم، هي الفنتريكولار، مساء الخير اولا. هي الفنتريكولار سنس ريسبونس عباره عن ان هو لو شاف في سنس immediately بيعمل بعدها باي فنتريكولار بيس او في بيس، بتبقى قدامك على الماركر في بيس عشان ما يخليش يزود نسبه البيسنج. سوري انا اسف، انا بره لسه عشان كده بس مش عارف اقول، الصوت مزعج شويه. يزود نسبه الفنتريكولار بيسنج عشان زي ما قالت لبنى احنا محتاجين دايما في السي ار تي، كلكم حضراتكم عارفين ان احنا نزود نسبه الفنتريكولار بيسنج. It's not a true زي ما هي قالت، بس على الاقل ممكن تبقى شبه سودوفيجن شويه، بس احنا بنحاول ان هو يكونتراكت يزود، عشان كده بحس ان ده انه بيزود البلاد الخارج من
كارديك اوتبوت. بالظبط
كارديك. هي دي الفكره.
هو الفكره ببساطه ان هو اول ما الديفايس بيشوف بيسنس في سنس بيدي immediately في بيسنج. ليه بيدي في بيسنج؟ just to يعني اوفر درايف الفي سنس ده، بلس ان هو يزود البيسنج ريت، الفنتريكولار بيسنج ريت، علشان هو لو سابها فنتريكولار سنس طول الوقت ده معناه ان هو البيشنت مش هيبقى حاصل له synchronization خالص. زي ما كنا بنقول ان هو this is not a true bi-V pacing، بس according to the studies لقوا ان even pacing the ventricle بعد ال V-sense بيحسن الكاردياك اوتبوت.
السلام عليكم، معكم دكتور محمد موسى.
اتفضل.
معلش كان في اضافه بخصوص الفنتريكولار سنس ريسبونس. يعني كان عندي فكره ان هي بتبقى مفيده في العيانين اللي هم البي في سي بيردن بتاعهم بيبقى عالي، بحيث ان هو معظم الفي سنس ده هيبقى عباره عن بي في سي وبيعمل معاه فيوجن باي في بيسنج، فبيحسن الريسبونس شويه. يعني دي الحاجه الوحيده اللي يعني ما بنقدرش نتحكم فيها فعلا عن طريق الباي فنتريكولار بيسنج او نزود الهارت ريت. فيعني اكشوال ببقى حافظها ان هو كونكت اف ريسبونس لو عيان اي اف، الفنتريكولار سنس ريسبونس لو عيان عنده بي في سي عالي، دول هو موست كومن كوزز بتاعت اللوس اوف باي في بيسنج.
هو بالظبط اكزاكتلي كده يا دكتور موسى، اكزاكتلي كده. ان هو كمان هو الفي سنس، يعني الفي سنس ريسبونس هو مش طول الوقت شغال، هو مش افضل حاجه ان احنا يبقى هو طول الوقت شغال، هو بيشتغل on accidentally basis. يعني لما بيشوف في سنس بيدي في بيسنج، بس it's not a true by V pacing. فdefinitely الدكتور المفروض يكوركت سبب ان مفيش by V pacing true by V pacing، لكن الفي سنس ريسبونس بيلحق الحاجات اللي ممكن تقع زي ما حضرتك قلت البي بي سيز and so on، عشان بس نزود الفنتريكولار بيسنج ريت اعلى من 90%. هو كان في اسئله، انا بس مش متابعه الشات بوكس، في اسئله تاني؟
ده يا ربنا كان ده السؤال الوحيد اللي موجود.
تمام. طيب خلينا في سؤال عن الادابتيف. يعني it's easy underutilized للاسف، بس ان شاء الله في الفيرجنز الجديده اللي هتنزل يعني it will be used ان شاء الله. طيب الفيكتور اكسبريس ده موجود في الكوادريبولار سي ار تي. فكرته ان هو اوتوماتيك تيست بيشوف ال 16 فيكتورز كوادريبولار فيكتورز، وبيعمل اسسمنت على البيس بولاريتي والريلاتيف لونجيفيتي والثريشولد والامبيدنس، ويقول لك افضل parameters which configuration to choose. It takes like maximum 2 minutes. طيب Victor Express 2 اللي موجود في السيرينا وموجود في الكلاريا والنيو فيرجنز اوف CRTDs بيعمل assessment على ال LV electrical delay، لأن يعني recently كانت كل الستاديز بتقول إن the electrode of at the site of the latest activation بتزود ال CRT responders أو respond rate. ففي Vector Express هيجي بيقول لحضرتك إن ال LV electrical delay في كل فيكتور قد إيه، and you choose the electrode at the site of latest activation. unfortunately ده لسه مش موجود، بس ان شاء الله في الامبليا والكلاريا والسيرينا هيكون موجود في النيو فيرجنز السي ار تي هتكون موجوده. الاتيني ستابيليتي ده ليد حاليا موجود في مصر، هو موجود في اقل من شهر تقريبا كان موجود، لسه يعني newly launched. الليد ده كوادري بولر بس، we used to have الباي بولر منه بس we phased it out، خلينا بس الكوادري بولر. الليد فيه short bipolar spacing to reduce الفرينيك nerve. أهم حاجة فيه إن هو فيه هيليكس للفيكسيشن للليد. الهيليكس ده بيساعد في الامبلانتيشن، سواء كان الكوروناري ساينس ليد short or wide. السكسس ريت اوف امبلانتيشن في الليد ده is 95% في الديفيكالت كيسز. هو يعني mainly بتبقى used في الديفيكالت كيسز او في الوايد فينز. Definitely lead is approved full body MRI scan 3 تسلا، و definitely be enable multi point pacing، وفي ستيرويد على كل الالكترودز to improve the threshold والlongevity. ده شكله في شورت فين. زمان كان في ميترونيك ليد تقريبا كان اسمه ستارفكس، كان فيه perforation ريت عالي. الستارفكس هو phased out تقريبا اكتر من يمكن 15 او 20 سنه كمان. الليد ده كان يعني ديزايند بحاجتين، اولا كانوا عايزين يحطوا safety considerations عاليه، كمان كانوا عايزين يعملوا ان هو يعني design lead while extraction is in mind. فعملوا ايه هنا؟ عملوا ان هم شافوا ان اقرب artery للفين كان 1 ملي متر average distance، عملوا الهيليكس ده ب 0.25 ملي، فمعناه ان احنا عندنا 4 times safety margin، فما فيش اي احتماليه للبرفوريشن من الهيليكس. ده الامبلانتيشن تكنيك، هو اتس فيري سيمبل، هو بيبقى روتيت كلوك وايز وانتي كلوك وايز كاونتر كلوك وايز. زي ما حضرتك شايفين كده just clock it wise then spin والهولد. فالهيليكس هنا بيثبت في الفين، release remaining torque, lead is fixated and stable. وبس تعمل fixation test بتبوش and pull، لو هو ثابت خلاص leave it في المكان التارجتد. اوكي، دي كل الستاديز اتعملت على الليد. كان في يعني very successful extractions، بس maximum كان على 27 شهر. فاحنا we cannot claim that very chronic extraction is safe، بس الترايلز اللي اتعملت almost كانت على 12 شهر extraction. It was successful without any percentage of perforation أو complication. فهو what is unique about الاتيني stability lead إن هو it was built لل difficult cases، لما يكون في مثلا wide or short coronary sinus plus it's built with extraction in mind. اوكي، آخر حاجة الريفيل لينك. sorry الديagnostics tools أو اللوب ريكوردر. insertable loop recorder اللي كان موجود في ميترونيك هو الريفيل XT. This one is phased out completely من ميترونيك. بقى عندنا البديل ليه هو الريفيل لينك. الريفيل لينك أصغر 9 times smaller than الريفيل XT، هو just 1 cc، وهو injectable يعني you can implant it in 1 minute or 2 minutes في العيادة من غير أي عملية. كمان even التكنيشنز والنيرسز بره بيعرفوا يركبوه. It comes with the reveal accessory اللي هو الأكتيفيتور. الأكتيفيتور ده بيستخدم لما يكون في for example البيشنت عنده atrial fibrillation, atrial tachycardia, and you want to store 100% of the arrhythmia. The patient press, we start the storage. طيب امتى بنستخدم اللوب ريكوردر؟ هو actually اللوب ريكوردر بيستخدم ما بين الكارديولوجيست والنيورولوجيست عشان الستروكس والسينكوبس والاتريال فيبريليشن. فأول حاجة البيشنتس اللي عندهم idiopathic syncops أو unexplained syncops، لأن زي ما حضراتكم عارفين إن already تقريبا 1/3 of the patients remain undiagnosed من السينكوبس ومحتاجين monitoring أكتر من 2 weeks holter. كمان البيشنتس اللي عندهم كريبتوجينيك ستروكس، أو لو في patient عنده atrial fibrillation asymptomatic atrial fibrillation and you need to manage إذا كان الميديكيشن is effective or need to be adjusted or not. We have the loop recorder. It's available now في مصر. الباقي الديفايسز يعني إن شاء الله إحنا هنعمل another session in deep details على technical لمثلا المايكرا لما نتفق مع دكتورة ميرفت. This was the last slide على الريفيل link. Any question? في سؤال؟ Thank you. شكرا يا دكتور أحمد. ميرسي لحضرتك.
شكرا جزيلا وشرح جميل جدا يا لبنى، ده جميل جدا، واحنا كده سعداء ان احنا قدرنا نتواصل معاكم في التكنولوجيا دي وفي حلقات اخرى. واي سؤال يا شباب؟ طيب نختم بقى، ولو كان بتوع دبي عايزين ميعاد بدري ممكن نعمل كده، يعني احنا مش ملزمين بميعاد معين، بس احنا بنقول الساعة 9 عشان كل الناس يقدروا يحضروا يعني. فلو كان المهندس او التكنيكال سبورت بتاع دبي عايز ميعاد بدري ارتب معاك يا لبنى وارتب مع احمد جمال، يكون بس يوم 2 عشان ده الميعاد اللي بنجتمع عليه. شكرا جزيلا يا شباب. حد عنده اسئله دكتوره لبنى؟ يلا تصبحوا على خير. شكرا.